I have the pleasure of introducing our speaker, reintroducing our speaker. Dr. Rachel Haroz is an associate professor in the Department of Emergency Medicine at Cooper Medical School of Rowan University and division head of toxicology and addiction medicine. She is board certified in emergency medicine, medical toxicology, and addiction medicine. She has spent the last 17 years working in inner city emergency departments, mostly in Camden, where opioid use is rampant. She helped build and now staffs the outreach clinic at the Urban Health Institute at Cooper University in Camden. In 2016, she helped create and implement an initiative to prescribe buprenorphine from the emergency department and bridge patients to treatment to various community partners. In 2019, she helped launch an innovative program aimed at initiating buprenorphine via paramedics in the field, and she's also heavily involved in education of residents, medical students, and pharmacists, and organizes education forums focused on topics related to opioid dependency and treatment. So everyone, welcome back, Dr. Rachel Haroz.
Thank you, John. I think you wanted me to go through and summarize some of the points from last week, is that right? Oh, and I have no disclosures.
Would you like me to drive the slides, or are you going to?
No, you can drive them. That's fine. We don't need to switch it up, so that's fine. So you can go to the next slides. And again, I think the point of all this, and by the way, thank you again for allowing me to come and talk to you. I know that you are the ones right on the ground, the ones interacting with the patients mostly, and you know, some of their biggest support. So thank you. I think the point behind all of this is that, you know, when these opioid overdoses happen, it's not the physicians and the nurses that are there interacting with the patients, but mostly it's either family or it's 911, right? It's paramedics, it's the EMTs. And while we use naloxone, and we should be using naloxone to reverse overdoses, it's really just a stopgap, right? It's a stopgap for what is happening. And so what we really need to be focusing on is resuscitating these patients, but also then being able to administer the actual life-saving medication that can allow them to move forward. And so that's kind of what this was all about, and moving EMS into an area where they can be provide more meaningful help and start these patients on this treatment. So we already went on through all this, and we did this last week. We talked a little bit about the medications that are in fact evidence-based, and how to encourage EMS to start administering these medications, understand these medications, and become part of that architecture for recovery. And again, you know, the important thing is really trying to approach this from a different perspective and try to use this new model to integrate this to EMS already functioning architecture. Again, I think it's really important that, you know, we want something that is sustainable. So bringing in all these mobile vans, while, you know, mobile vans can be helpful, and especially, you know, in some more rural areas, the truth is that all this already exists, right? It already exists in the form of EMS. So why not utilize something that exists, is trustworthy, and they're already medical personnel that know how to approach patients and administer medications. All right, so let's go through some of this. And I showed you this last time. You know, we're in Camden, New Jersey, where it's a very small area. It's about 70,000 people, about 35,000 EMS calls. Cooper itself has medical school. We're a tertiary care center. Our ED is fairly busy. We have a lot of overdoses, and we have a lot of morbidity associated with IV drug use. While most of our overdoses happen in the field, over the last few years, especially 2018 to going to 2019, we had a decrease of patients actually being brought to our healthcare system. As much as our healthcare system was really focusing on trying to provide this amazing care, patients were getting to us because and we're not 100% sure that it was because of decriminalization, but I think decriminalization certainly played a part. And don't get me wrong, I think decriminalization is incredibly important. But what ended up happening is patients chose not to go to the healthcare system. They don't trust the healthcare system, right? They haven't had great experiences there, and so they chose to stay. So it caused a barrier between us being able to treat these patients. We also know that there are great medications, buprenorphine and methadone, that do decrease mortality by almost 60%. And I always put up this one little graph that shows you just how incredibly impactful initiating and maintaining these medications are. And we also know that, unfortunately, despite the fact that we have this evidence, about 20% of patients only receive these medications, and 80%, unfortunately, are without. And I don't know if anybody saw the New York Times this morning and just the data coming out over the last few days. We know that 2020 increased overdoses in this country by 30%, which was horrible, but last year brought another 15% increase. And now we're at about 108,000 that died last year. So unfortunately, as much as the percent decreased, 30% increase to 15, so maybe it's slowing down a little bit. What we know is we still lost really an inordinate amount of individuals last year, and we really should be doing better at this point. You know, bringing this to EMS, and I think, again, I know some of the questions really address this, is, you know, how do you bridge that culture gap, and how do you create a paradigm shift? I talked a little bit last week about how we focused on a lot of different interactive methods. We did some live instruction, we came in person, we recorded some webinars, we did journal club. We took these paramedics and we had them spend time one-on-one with physicians in clinic so they could literally interact and talk to patients on the other side, right? So patients that were no longer in the basements, but now actually coming to clinic, getting medication, et cetera. And then, of course, embedding physicians to model this behavior on scene. This is our protocol for us. Because of our state rules, it did have to be in the setting of an overdose and after somebody had received naloxone. We did have some exclusion criteria, primarily if you had received methadone or were pregnant. Neither really matter, honestly. And if I had to do it again, I would not use those as exclusion criteria. And then, of course, if you had unstable vital signs, if you were not alert and oriented, but you did have to give consent. And then initially we used a COWS of 7 or above. We don't do that anymore either. If you receive naloxone, if you're willing, we will give you the buprenorphine. Our dosing strategy was 60 milligrams of Suboxone. And I specifically say Suboxone because that is what we used. We did not use plain buprenorphine. As a matter of fact, we started with the tablets. They didn't dissolve well. So we switched over to the strips. And then 4 milligrams, and I apologize, it should say Zofran. And then if they were not much better, we gave them another 8 milligrams of Suboxone. And then they had the option, if they wanted to, they could come to the emergency department. Most chose not to. And then they were given an appointment for the next day. We know that about 10% accepted and about 44% of those made it to their first appointment. May not sound like a lot to everyone, but in the world of addiction, it's actually quite high. Remember, these are our most vulnerable patients. And then the one thing that always concerns people is how, does it increase on-scene time? Our average on-scene time was 24 minutes, which was plus minus about six minutes more than usual, which is not really significant and did not worry our EMS colleagues. And just some more data. Our average COWS was about 9.6 for these patients and decreased to about 3.3. The vast majority received about 2 milligrams of Narcan. I will say that more recently, these numbers are a little bit higher because bystanders are very active in this, right? So a lot of people carry naloxone now, and a lot of people want to administer it. So sometimes by the time EMS gets there, they've received 4 and 4 intranasally, which is, way too much, but it is what it is. I'd rather have them get Narcan than no Narcan. Our barriers continue to be our barriers. Nothing is ever perfect. Our biggest one probably at this point, and I should probably switch it up and make it the bigger one, is that patients are worried about being precept. In a community where we predominantly have fentanyl, where predominantly patients use really, really very large amounts of fentanyl, the fear of being precept is very real. And so that's something we have to talk through with the patients. I will add to our data, just so you know, nobody has ever gotten precept, and we're up to 175 patients approximately, maybe even 180 at this point. Nobody has gotten worse. Everybody that received naloxone and then buprenorphine got better. We have a fairly large group out in California, and one of the in the counties outside San Francisco. They adopted this about maybe a year after we did it. at our protocol, and they have found the same. They have had nobody get worse. So I'm going to put that out there because I know some people are concerned about that. And then, you know, just reminding providers that this is an option. Being in EMS is tough. It's causes a lot of burnout, but reminding them that this is an option is really what this is all about. So happy to answer questions. And I know that, John, you said you're going to drive some of the questions that are being asked on top of the ones that you put in here.
Correct. Yeah. So we have some questions that were submitted, but if you have a question or if it leads to another question, please, the reason we're here is to answer your questions. So please do send messages, raise hands, or even just say your question out loud. So someone asked what precept is. I could answer it, but I'm going to let Dr. Haroz answer it.
So I'm sorry, I really should have been more clear on that. So when I say precept, I mean precipitated withdrawal. So one of the things about buprenorphine is that it has a much higher affinity for the opioid receptor than most other opioids. In fact, the affinity is pretty much close to that of fentanyl. And I'm sure everybody here knows there are between 500 and 1,000 analogs of fentanyl. There is a lot of fentanyl, and they're all just a little bit different. So but buprenorphine really competes. And so what happens is if you've got a full agonist on board, right, you've got this fentanyl on board and you give them the buprenorphine, it's not that different from naloxone. It'll suddenly drop them from a full agonist state to a partial agonist state. And that feels horrible. That feels like a sudden withdrawal. Again, not different than naloxone. And so patients who have experienced it are traumatized by it, and they're just so afraid of having it happen again. And it's more prolonged because buprenorphine lasts longer. So that's what precipitated withdrawal is.
And then we have another question. Do I understand correctly to say that 2 doses of 4 milligram Narcan intranasal by standards is too much?
It's too much. Yeah. You don't ever want to give that much. You don't need to give that much. In fact, that would worsen withdrawal. So it's kind of like if you've got a cardiac arrest, right, and you're dosing somebody with 1 milligram of epinephrine, but over the course of the entire arrest, maybe you gave them 1 and 1 and 1, and then somebody says, hey, you should give them 3 milligrams to start. That's not how we do it. That's actually not how it works, and that's dangerous. And so no, I definitely don't think 4 and 4 is good. And actually, those are the patients that do get fairly sick. But again, it's bystanders, and I don't ever want to tell bystanders, don't give naloxone. I'd rather they give the naloxone because I want these patients breathing, even if they're sick.
Right.
Do I have to ask a question, John?
Yes.
Yeah, Kimberly, sorry. Thanks for being here, Dr. Haroz. But I heard you mention the calls a second ago, and you said at first it was a 7 to 8 score on it, I think, or I misunderstood. That's really what I'm asking. Do you no longer use that, or is it a lower score?
It's a much lower score. So basically what happened was this, we started off and we honestly, we didn't know what we were really doing, right? So this is back in like 2019, and we had gotten this 250,000, and they were like, you got to put a counselor out there. You got to have them talk to the patients. And we were like, that's crazy. Nobody wants to talk after an overdose. But we really wanted to give patients buprenorphine. But we also at that time, so 4 years ago, we knew that you were supposed to give buprenorphine when somebody had a high COWS. So high COWS, you give buprenorphine. And so we established these guidelines, because you need guidelines when you're starting to do something, right? So we said, okay, let's use 7 to 8, because that's what we were using in the ER at the time. And what we found is that the medics were like, oh, I think I gave it to with a COWS of 6. And then another medic was like, oh, I think the COWS may have only been 5. And what we realized is that it didn't actually matter. Patients had a COWS of 2 or 3. We were giving it to them and they were still feeling well. But now they had the buprenorphine on board. And so now they were protected for 24 to 36 hours. And you gave them a little breathing space because they didn't have to worry about getting their next bag. Right. And it allowed, you got them thinking a little straighter. You gave them the referral. So yeah, it actually seems like the COWS does not actually matter.
Yeah, as a person who's been given the COWS many times, at some points it could almost be torturous trying to get your score up high enough to be dosed. So that's really great to hear that. Thank you.
Yeah. I will just qualify by saying that's in the setting of somebody who received naloxone. So somebody who has not received naloxone, we still do want them to have time from last use and a higher COWS. But that's a different conversation because there's ways around that as well. First question is, what is the best way to engage EMS? And knowing what you know now about your program, how would you start engaging and training EMS? So I think one of the things that happens across healthcare is that we're very siloed, right? You've got the ED, you've got the hospital, you've got the outpatient, you've got EMS. And so I think one of the very first things is that you as much as possible, make EMS part of the bigger system, right? Engage them, engage EMS with your outpatient, engage your EMS with your ED. And the reason I say that is because when they're engaging with patients, you want them to be able to talk about all this in a very familiar way. Yo, you're gonna go to this clinic, they're so nice. They actually have coffee in the lobby, right? You want them to be talking about it like they actually know about it, rather than like, yeah, I don't know, you're gonna see someone somewhere, I don't know. The other thing is that you want to talk to them about what their concerns are and how they feel about the, about what they're doing on scene. I think what you're going to find across the board is that they're frustrated. There's a lot of burnout. They feel like they're really not, I don't know, I'm giving them Narcan. Sometimes they come with me, sometimes they don't. I'm going back to the same houses. And I don't know if you guys have leave behind naloxone, but they may, but again, like you're just reviving these patients. And then what? One day you're just not going to be able to revive them. You're going to get there too late, right? So I think talking to them about the mission, having them own it, and then showing them teaching them about what medications for opiate use disorder actually are and how incredibly effective. I can tell you that when I touched them, they were blown away. Like, what do you mean we've had this medication that can actually change lives, save lives, and alter mortality? Like, where has this medication been? Also remember that methadone is despised by people, right? So just the word methadone makes people cringe. I remember as an ER doc, we'd get a call on command phone saying, hey, we're bringing somebody from the methadone clinic. It was a big game of like, not me, I don't want the patient from the methadone clinic. We're just terrible, right? I mean, methadone is a perfectly effective medication and saves lives. So I think all those things, there's a lot of education. It's a lot about collaboration and personal relationships. Yeah. And again, training as much as possible in person, at least in the beginning. And then, having information available if you have websites so that they can download stuff, read it, watch webinars, etc.
Thank you.
What roles do peer support specialists or care navigators play at Cooper? Are peer support specialists, social workers, case managers, care coordinators that are integrated on EMS runs or into the ED? Are there other avenues for patients linked to MOUD to get peer support? And then so let me just start. So we actually don't utilize peer specialists as much as we possibly could. And it's a little bit complicated, and I'll be very transparent about our experiences with peers. So peers were initially placed in our ED in January of 2016. And actually, we didn't know about them. So like one day they just sort of, they just showed up. Our peers were not hospital employees. They weren't part of addiction medicine. They were placed there by an agency contracted with the state, and that agency was abstinence-based. So it was very hard to kind of join their philosophy and our philosophy. And so these peers, and again, like even though we lectured to them and we try to really engage them and teach them and help them, it's very hard, I think, especially since so many peers have lived experience. If you've achieved sobriety through abstinence, you're less than 10% of everybody, right? But it's incredibly powerful. And so these peers were just so motivated to help people that it was very hard to let go of their own belief in what heals, and to embrace this other philosophy, which remember 6-7 years ago was still like a little taboo, especially in a lot of those circles. And so I think peer specialists can be incredible, and we actually have 2 care navigators that we work with at our in our actual addiction side, so not the ED, but on the addiction medicine side, and they have lived experience and they're amazing. But they also went through the training. We supervise them. They come to us with questions. Now on the actual EMS runs, there's nobody. And the reason there's nobody is because when you have been through an overdose and when you wake up, you feel bad. You're not going to be talking a lot. Like the only way, and again, like, we don't want to place extra people on these trucks, right? Because we want it to be sustainable. So we want to teach the medics and the EMTs to have these skills so that when they're in there, they're not bringing an extra person, but they are the ones that can engage. They are the ones that are like, hey, let me take my blood pressure. Let's talk. How are you? I'm glad you guys called, right? You want to actually teach them the skills. At least that is our philosophy. That being said, once they arrive in the ED, and then, or even more, once they arrive in our clinical space for addiction medicine, there we actually have case managers, navigators, we have all that. And we do a lot of wraparound care in terms of housing, food insecurity, et cetera, to help them move forward. What types of roles were most critical in getting engagement from EMS staff, and what type of evidence discussion helped EMS staff who were reluctant, not interested? Yeah, so we had a subcategory of EMS that were very, very resistant in the beginning. It really went against their philosophy of everybody needs to pull themselves up by their bootstraps. I am not here to fix you. You need to, if you're strong enough, you would do it, survival of the fittest, So I think engaging. And then I think, so we would use good outcomes and feed them back to and I did this with the physicians, with nurses, with EMS. So let's say they gave somebody buprenorphine in the field, and let's say the EMS supervisor is there, and the EMS supervisor was very resistant, but hey, the medics already gave it. That patient then showed up in clinic. I would then call the EMS supervisor and be like, hey, that patient, they did so well. They showed up, they're doing well. They re-engaged with their family. And that kind of made the EMS supervisor feel like, oh, wait, hold up. Like, I did something good there, right? And so and I did the same with the physicians, like the physicians that in the very beginning, when they were so resistant, back in 2016, they were so resistant to writing the scripts. I would give them that good feedback, like, oh, that patient showed up. They're doing so well. They're so grateful that you got them started. Then they're like, oh, wait, hold up. I got to do this more, right? So I think that kind of, and then again, just one-on-one engagement. I think EMS really feels separated a lot of times. They show up, they're like, nobody's happy about EMS showing up with more patients to the ED. So creating like, thank you for bringing this patient. I'm so glad you engaged with them. Let me tell you what happened, I think is critical.
I had a quick question about when you did have peers or care navigators in the ED, did you have to do a lot of like trauma-informed care training just because of all the noise and smells and chaos that an ED creates? And did you see high turnover, that kind of thing?
Yes, that's a really big question, actually. So we have worked very, very hard to try to bring trauma-informed care to our ED, and we have not been successful. The training. And one of the things that I have looked at across the country is who is doing trauma-informed care in the EDs. And I'm really embarrassed to report back that there's a very, very few single EDs across the country that have tried actually teaching and bringing trauma-informed care. I think trauma-informed care is important for everyone. I understand that for peers, it's even more so because they're in this highly charged, very, and they haven't grown up in it. But for many of our staff, they are from the community. And even our physicians and our nurses, this really piles on. And if they don't understand, a lot of the concepts that are taught in trauma-informed care, if they don't understand their own responses and the responses of their patients, I think it tends to escalate everything. So no, we haven't done that. But again, if I were to do this, in a better way, I would 100% do trauma-informed care. Again, not just for the peers, but for everybody involved in this, including EMS.
Thank you.
How has Cooper EMS gained the trust of people who have overdosed and eligible for the program? The refusal rate was really high. Now that the program has been up and running, is there a sense of trust? If so, was it a grassroots word of mouth, and how did EMS build rapport? So this is actually really interesting because after we launched this, about a year and a half after we launched this, one of the things that we found is that our EMS vehicles were being stopped by people on the street. Basically like, hey, are you the Bupe truck? Hey, are you the Bupe truck? And so they actually started to be seen as those that can link patients to care. I will also say that a good portion of our EMS staff started to take it upon themselves to seek out some of these patients. So in between runs, they would peek under the bridge and be like, hey, who's under the bridge today? How you doing? Do you want to be linked to care? We can get you in the very next day. And I think once they started going from an area of only showing up when overdoses happened to this engagement, it really did a lot. I think it did a lot both for the patients and for EMS. And so yes, trust has significantly risen, more so than, you know, probably with anything else that they've done in the community. I will also say one other thing, which, so geographically, if you look at Camden, we're across the river from Philadelphia. And Philadelphia, as people know, has Kensington. And Kensington is the largest open air opioid market in the world. And I don't know if any of you have ever been to Kensington. I mean, there's areas that are just tense and tense and tense, and you can literally drive through and watch patients actively inject. It's a really tough place to be. One of the caseworkers from Penn who goes out there, and there a lot of street medicine happens, right? So there's places in Philadelphia, like Prevention Point, they go out, they engage with patients on the ground. But one of the caseworkers actually said to me a couple of years ago when we first started doing this, she said, you know, I was out there and people talk about Camden and Cooper. They say, like, if you want care right now, just go over the bridge. Just go over the bridge, they'll get you right in. And that to me was so powerful, because that is word of mouth, right? It is people talking about it and saying, okay, these people care, they'll get you in. So yes, I think more than anything, it's very grassroots, it's very word of mouth.
Let's see. Have you ever had someone that was on an EMS team that did the opposite of helping? Has there ever been any reports of EMS abusing the fact that they have medication and refuse people out of meanness? And if so, how was it handled?
Interesting. I haven't had any reports of that. I think if anything, rather than refuse, they simply maybe won't offer it. You know, we definitely don't have 100% rate of paramedics offering it, especially if it's like a really crazy scene. We've had patients that were in bathtubs and, you know, there's water everywhere and people screaming and other intoxicated individuals. And so they, you know, they felt unsafe and they just wanted to, you know, scoop and go as fast as they can. We have not, I am not going to sit here and tell you that every single paramedic, every single EMT is amazing. Because that is not true. That's never going to be true, right? There's always going to be some that are having a bad day, that have personal issues, that have personal history. It's always going to be the case. But what you want is you want a kind of a bigger shift, and you want sort of a bigger shift in behavior. But I think you're always going to have individuals that are, you know, not going to be acting with the whole. And I think that's true for everywhere.
Does anybody else have any? Let's see. Oh. Thank you for that message. That's incredible to hear that those two populations, both patients and EMS, kind of one going from, you know, reluctance to treating a population to seeking out to try and find people, and then another group that with a 40% refusal rate, you know, telling people how to access care. That seems like a huge shift. So thank you for sharing that. Let's see. As you said, many peer supports have lived experience. Have you experienced an increased rate of relapse with those working at or near a point of care?
So we have had some peers that have relapsed for sure. Not mine personally, but the ones that worked in the agency with us. I don't think the rate is very high, but I definitely think it's hard as a peer, right? Because you are constantly exposed. There's triggers. Sometimes you got your walls up and sometimes you don't. And so I think when peers are working there, I think it's really important for them to have, you know, solid supervision, somebody that they can talk to, constant check-ins, reviewing of patient care. We had some really crazy stuff with peers in the beginning. We had peers asking patients out. We had peers that showed up dressed completely unprofessionally. We had peers that removed patients from the ED to go get a burger. Right? Like there's just, and again, it's just part of it is that if you come from a different environment, you may not know how the ED functions. So I just think training and supervision and constant check-ins are so incredibly important.
Would any of the peers on the call like to talk about any of the trainings that you have specific to that idea of like being close to, working with patients and things like that? Is there trainings or is there protocols in place at your organizations to kind of, I guess I don't know if I'm asking the question right. Does anybody know what I'm asking?
I'll try to tackle it for you, John. So
Thank you.
maybe, yeah, we do have a peer support supervisor that we check in with, and we're required a group once a month, and we're required a session one-on-one once a month. And so we always have her available if needed extra, and we do get together on, like, we pick one day and like every 3 or 4 months, and we're trained on, we did do trauma informed care the last time we got with a domestic violence person, and we learned about helping others seek, if they were in a domestic violence situation, like how we could help them best seek care. But we we always have our program coordinators too, like if we have questions or if we feel like our placement is too much or too stressful or need to switch out, or that's always an option. So we always have them to go to. But as far as the personal level of being a peer and working in a role where I'm faced with people every day that may still be actively using or still may be at the beginning of seeking treatment, I've never say that I've been burned out. If anything, it's gave me the drive to be out here more to help them find what works for them. Because I guess for people like us that know what it's like to be on that reverse side, and then to where we are now. So there's a big gap there. It's like your drive is to help everybody get where you are now. So, but there are many options for us in our position at Voices, at least. I don't know for other peers and how that works, but we have lots of support and various avenues to seek help if we find that we're in trouble.
Thank you for sharing that. That does answer my very poorly worded question. So thank you.
I just think it's so hard because, I mean, I have one specialist who she achieved sobriety during pregnancy. And so for her, when she sees these pregnant women that are struggling, it's hard because she just wants to help them so much, but it's also so powerful because she can talk to them in a way that I can never talk to them, right? Like I can give them the evidence, but I will never know what it's like. And so she'll just go in there and she'll connect with them on a totally different level. But I can see that it's hard because she's like, oh my God, why can't, like, I'm so upset. She's still, there's this bait. Anyway, so I think it really can be both sides. And I think having that support, I just think is really important.
Great. All right, let's see.
What role did community partners play in the rollout, and did the program need community partners or champions to assist? And was there advertising or education? So a couple things. We, in the beginning, when we first rolled it out, we simply didn't have the capacity to take all the patients, right? We were fairly, I wouldn't say small, but we were small enough at the time, and we really had no idea what the capacity was going to require. So, however, we did have 2 FQHCs in Camden, and again, Camden's fairly small, so geographically it makes it easier. But we did have 2 FQHCs that were prescribing MAT and that were willing to take a day each. So if I remember correctly, one of them took Tuesday, one of them took Thursday. So the way they did it is they're like, hey, we will have slots open at 9 a.m. on Tuesday and 9 a.m. on Thursday. And then we handled Monday, Wednesday, Friday. And so we partnered with them. And then so if a patient was being seen on a Monday and bridged to a Tuesday, that patient received a card that said, hey, you're going to Cam Care tomorrow, 9 a.m. or hey, you're going to Project Hope tomorrow, 9 a.m. So we did it that way. And so that's, and we let those FQHCs know what we're doing. In terms of advertising or education, no, we've actually never advertised or really gone out. We will partner with organizations that want education in their spaces. Absolutely. So if an organization comes to us and says, hey, can you come and talk about XYZ? Of course, no problem. But in terms of us initiating sort of advertising. We've really let this be word of mouth. Part of it is that we have grown so exponentially. I mean, I cannot even, we're growing so fast we can barely keep up. We're just double, triple booked for every appointment. So I think we worry that if we advertised, we simply would not be able to keep up with the capacity right now. I think maybe one day in the future we will advertise, but right now we're just really trying to keep up. And just for clarity, we have right now, I have 9 physicians and 6 APNs and 4 or 5 therapists and a couple of navigators. So we're a fairly large staff. We have about 1,100 patients that we see in our outpatient clinic. Are there other EMS buprenorphine programs, and have these programs seen the same success as Cooper? So there are several. California, right outside San Francisco, was the first one, and their results really have mirrored what we did. Austin and San Antonio both started their own programs, but their programs are a little bit different because they do not just do overdoses and those that receive naloxone. Rather, their paramedics just carry buprenorphine. They have physicians and paramedics on their trucks, and they basically will treat withdrawal. They'll treat anybody that wants to start treatment. And I actually don't know. They say they're fairly successful. I have not looked at their data. Pittsburgh just started their EMS bupe program last year, and I have not talked to them very closely to know what the results are. I also know that there are several programs in the Carolinas. Also, these are all based on our program, but they kind of adapted them to fit their communities.
Awesome. And we can, in the newsletter, we'll link to some of those programs. So if people are interested in seeing other programs, and I think we have access to the Cal Bridge protocol so that we can put that in the newsletter as well if people are interested in looking at the different protocols. Let's see. What would the best way for peer navigators to advocate for a program here in Fayette County, Kentucky, which yeah, I don't know if Dr. Haroz can answer the Kentucky part, but I guess she can attempt to.
Tell me, so Nick, tell me more. Is Fayette, is that a rural, fairly rural? Is that urban? Like what kind of community?
I should have been more specific. Lexington, Kentucky. It's a urban area with 3 large hospitals, I think.
So we have had quite a bit of inquiries from large hospitals and EMS services across the country. They haven't launched anything, but they're in that, you know, we've been meeting people in Minneapolis, et cetera. I think the first thing would really be to talk to your EMS leadership and emergency medicine leadership. And then if you have addiction services already in place, kind of bring those together and see if they want to start talking about it. I spend a lot of my time talking to different agencies, and then Dr. Carroll, who I work with, who is our EMS director, he spends even more time talking to all these agencies, and it's much easier for, and actually even just bringing him to talk to the EMS people, I can do it, but I'm ER addiction. He's actually EMS. He was a New York paramedic during 9/11, actually. Like, so he spent a lot of time on the ground as a medic before he turned around and went to medical school. So he can really talk the talk and talk about it from an EMS perspective. So I'm happy to connect you to him if that group in Lexington would, you know, were to be interested in doing some preliminary talking about that.
Thank you, Doc.
How hard?
Sorry, go ahead.
Sorry. So how hard was it to get the buprenorphine, the Suboxone on the EMS?
So it was illegal at first.
Right. Right.
Yeah. So it was a little bit tough. But one of the things in New Jersey, and I don't know what the Kentucky statistics are right now, but New Jersey has just had crap for overdoses, like, right? We just have done so poorly. And we're such an incredibly densely populated state that we're so small, and yet we've had so many overdoses, especially in areas like Camden, Newark, Patterson. And we had the ear of a very open-minded health commissioner. So the first thing we needed to do is to change the law, right? So to give us a directive, executive directive that allowed EMS to carry buprenorphine. I mean, they're allowed to carry morphine and fentanyl and you know, Valium. I mean, all these other controlled substances. These are not you know, these are very highly educated individuals that have, and again, buprenorphine is such a safe drug compared to all of these other medications that I just named. It is way, 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 way safer. So I think that, you know, I think first making sure the legality is there, and then it also depends on who actually stocks your EMS meds. So for us, we're super lucky because we do. Our institution stocks them. So we simply just added it to the list once the executive order went through. So.
Okay, thank you.
Yeah. Oh, and John, please feel free to share my email
Okay.
with people, because I honestly, like, I'm, you know, reach out. I'm happy to help. I may or may not be able to answer all your questions, but I'm happy to try.
I definitely will do that. And thank you for making yourself available that way. All right. I guess this kind of led into and talked, I guess you already talked about it one way, in the sense that you have to get buy-in from EMS, or you have to check the legality, or you have to get buy-in from the ED, right?
Yeah.
But there is a sub question of, what advice would you give, or do you have examples of programs when the EMS is not run by the same organization?
Yeah, so a couple things. The first is that every EMS organization is going to have physicians at the top, right? You have to, like, that's literally how they're set up. So you're going to have physicians, and by and large, these physicians, you know, it's a lot of times there's also paramedics, nurses, don't get me wrong, but somewhere in there, there's going to be a physician, and that physician is probably going to be emergency medicine, because that's who falls into the EMS. I actually have never even heard a physician running EMS that is not coming from somewhere in the world of emergency medicine. So really getting in touch with them. So we actually have a group in New Jersey right now that we're hoping is going to start this work. We're just waiting for grant money to come through. And they're not hospital based. They're actually not based out of a hospital. They're an organization that partners with the hospital. One part provides ALS and one part provides BLS. Remember that ALS does get fairly closely supervised, and ALS is almost always tied to a hospital. BLS can be volunteer, it has fire, you know, based on fire, it has a lot of different ways to supply BLS, but ALS has to have a hospital affiliation because they, you know, because of all the medications involved, et cetera, et cetera. So that's, you know, that's, I think, just getting in touch with those individuals and partnering. Again, it's at the end of the day, this is so much about collaboration.
It looks like, so just curious, is there any training curriculum that you have regarding cultural humanity or cultural competency to improve health outcomes as EMS goes in different communities that have a historical distrust, like communities of color or unhoused people?
So I'm really glad you asked that question. We have tried very hard through our healthcare system to incorporate DEI training. And again, a lot of people end up just folding it into trauma-informed care. It doesn't have to be part of trauma-informed care. Like, not all DEI care and not all cultural competency lives in trauma-informed, but it does get folded in quite a bit. I don't know that we do as good a job as we should and could. And you're right in a lot of ways, like, our EMS does not always reflect our community and the ethnicity of our community. And so I think that that's super important. And the answer is no, we have not. I don't think we've done a big job doing that. We've incorporated here and there because it's part of our kind of our healthcare's mission right now, but we have not done a good job.
Does your program have any family support services and provide education? Family support can increase retention rates.
Absolutely. We actually had more family therapy early on. COVID really put a big dent into a lot of our work. I mean, it's interesting because COVID on one hand made us pivot very dramatically and create an entire low barrier walk-in part of our clinic. So every day from 1:30 to 5, you can walk into our clinic, no questions asked, and you will be seen by a provider. And we did that during COVID because other people were closing their doors. But one of the things that did suffer was the, you know, a lot of the family work that we had done by bringing family in, et cetera. So no, we don't have nearly as much as we should.
There's a follow-up question about retention rates. Someone trying to, okay. How do you have the long-term retention rates for the, at what point do you know, stop tracking or that kind of thing? Because it.
Yeah, so we have, and I think, I mean, we're publishing something hopefully very soon. Our retention rates really vary, and they're very up and down. Our overall retention rate has been closer, like our initial show up rate is 44%, then obviously it drops down. Of those that show up initially, it's 61%, but it can vary anywhere from 30 to 60%. And I will tell you something else, which is really interesting, is that we do retention, but we do retention over a long period of time. And the reason we do that is that we, you know, we'll do 6 months, but we do, you know, one of the things that people look at a lot is like, did they come every single week? Did they come every single month? And people don't. I mean, I don't know if you guys, I don't go to the doctor when I'm supposed to, right? But the fact that patients come back, right? So we have a lot of patients that we've been seeing for 7 or 8 years, and maybe they'll relapse for a while, and then they come back, and they know they're always welcome, so they come back because we really try to treat them with respect and compassion every single time. And I think that somebody is going to achieve sobriety and then never have an issue again is I just don't know how realistic that is, right? Because this is a chronic disease. So like diabetes, sometimes it's a little easier, sometimes it's a little bit harder. Of course, we all want abstinence and, you know, sobriety and life goals and all that. But I think if you paint that picture all the time, then patients are going to feel like they just failed. Well, I've failed. I'm not going to go back and see Dr. Haroz again. Like, I don't want her to think I'm a failure. Instead, we tell people, like, it's, you know, if you relapse, that's okay. That's literally why you're here. You have this disease. Okay, let's talk about what happened. Let's see what your triggers were. Let's see how we can do better next time. And I think that's the message we try to send. It's a chronic disease. We're in it for the long run. You know, we just really don't want you to die.
Great. Are there any other questions? Nick just said that being forced into abstinence almost killed him many times. So thank you for sharing that. And
we know that, right? We know that patients coming out of these facilities where they are abstinent, their relapse rates and their mortality is insane. It's really high. It's dangerous to make somebody be abstinent because, again, when you're abstinent, your tolerance goes down, right? So one bag, it's half a bag can be all it takes. And that's not fair. It's not right.